Well, welcome everybody. Can everybody hear me? If you can just nod if you're on mute. That's great, thank you. My name's Kath Maloney. I'm the CEO of Sarah, and it's my great pleasure to welcome you all to our webinar today. And a big thank you to those presenters who are going to be sharing their experiences of the Allied Health Rural Generalist pathway with us today. I just would like to begin by acknowledging the Aboriginal and Torres Strait Islander peoples as the traditional custodians of the lands in which we're meeting today, and pay my respects to elders past, present and emerging. I am going to hand directly over to Gemma Tuxworth, who is our Principal Project Manager for the Rural Generalist Pathway, the Workforce and Education Scheme that Sarah's currently implementing. Gemma is going to chair the meeting from this point. So Gemma, over to you.
Thanks, Kath. Sorry, my dog is in the background going a little bit berserk. This is the perks of working from home, so I do apologise for that. Right, so, thank you, Kath, for the introduction. And welcome to everybody. I think we have quite a few here now. And I hear lots more doorbells indicating that there are more people joining us. So that's great. We'll get started. Many of you, obviously, those that are presenting today are well aware about what the trainee program is. And hopefully those that have joined to hear about these projects have a good understanding of the program and a good interest of what's going on, and that's why you're here today. So far we have implemented the training positions in 6 states and territory health services. Kath did send me, Kath, have you got the figures of the updated numbers there? You did send them to me, I apologise, but I'm having technical difficulties and I can't see them on my screen at the moment.
Yes, there are currently about 72 active traineeships across Australia at the moment. Did you want me to find them and talk about that? Or
that's fine. Yeah? I guess I can just say to the group that one of the big exciting things that has happened is we've recently started trainees in New South Wales, in Marathon Health, and in Tasmania with MathWorks, which are private organisations who are going to be having trainees join them as well. So that's really exciting. We're sort of expanding the Allied Health Rural Generalist into the non-state health jurisdictions, so out of the state health services, and looking at other areas that it can be applied. So that's great. Today we've got we're showcasing 6 rural generalist trainees and the service development activities that they have done, as well as their experiences with the pathway. And hopefully that will generate some enthusiasm and some discussion about the pathway going forward. So summarising, we've got an Allied Health Rural Generalist training position, which is focused on early career positions. They might be new grads for the level 1s, or for the level 2 it might be those with 2 to 3 years experience. It's a work integrated learning program, so your learning is supported through your work, and that again is supported with training and supervision, dedicated time in your workplace. You have a profession specific supervisor, and we aim for that where there's new grads and level 1 trainees. We aim for that person to be co-located at least 50% of the time. And one of the big, the third element, or the big keystones of the program, is being involved in a service development strategy. And that is why you're all here today, to either talk about or hear about some of these service development strategies that have happened. So without further ado, we'll get involved with it. And we're going to kick off with Emma from Queensland. Now, just on the side here, you'll notice that we're going to have accumulate questions throughout the session. If you can use the chat function on your Zoom. If you can't see it, if you're new to Zoom, if you hover over your Zoom window, you should see a settings option somewhere, and there'll be a little chat window which you can then type your question into. Kath and I will try and collate those throughout the session, and depending on what time we have available at the end, we'll direct some questions through to the trainees and their supervisors as able. If we don't get a chance to get to those questions, we will try and record document them down and get answers for you out of session that we can distribute. So now, Emma, I can't see you. Oh yes, I can see you now. Would you like control of this, so or do you want me to just flick through the PowerPoint for you?
Yeah, if I can get control, I will. Might make it a bit easier.
All right, let me give you control.
Excellent.
All right, have you got that?
Yep, perfect. Well, welcome everyone. So my name's Emma Riewald, and I completed the stage 1 and stage 2 of the Rural Generalist pathway in December 2019. And today I'm presenting on the project I completed as part of the stage. Oh, it says I'm muted. Can you hear me?
Yep.
Okay. And I don't think I have control. Oh, there we go. Just a bit impatient. So stage 1 program titled Speech Pathology Management of Adult Patients with Dysphagia using telehealth across Gladstone and the Banana region. The project included 5 sites in total in central Queensland, including Biloela, Mowra, Theodore and Bralaba, which are all situated in the Banana region and Gladstone. The project term was from June 2017 to June 2018, with project outcomes evaluated 12 months post-implementation, and the project sponsor was Stuart Orr. So the aim of the project was to develop and implement an allied health assistant supported telehealth model of care for the management of adult patients with dysphagia, referring to swallowing difficulties, which improved access to timely speech pathology services, maximised clinician efficiency by reducing travel time, improved the patient journey with closer to home care, and enabled service continuity in times of no local speech pathology coverage. There was a need for this project as a speech pathologist in the Banana region was based in Biloela 4 days a week and serviced the 3 outreach sites on a referral basis, each located approximately 1 hour away. On receipt of a speech pathology referral from an outreach site, the clinician was previously required to complete the consult face-to-face. So if the patient was in an acute setting, it meant that the scheduled outpatient appointments for that day were often cancelled, increased travel time for the clinician and longer wait times for patients, with potentially reduced quality of life associated with them then having to remain nil by mouth until the speech pathologist could see them. In 2016, the Gladstone and Banana Allied Health Work Unit merged, and under the 2016-2017 Queensland Government Rural Revitalisation Funding Scheme, the Banana Allied Health team were able to appoint 3.5 FTE allied health assistants to be located in each of the 3 outreach sites. So collaboration and professional support across Gladstone and Banana, as well as the increase in allied health assistants, meant there was workforce feasibility for this project. Hopefully that next slide pops up shortly. But some of the key activities involved in the service development included liaison with rural and tertiary facilities, in particular the Gayndah Allied Health team and Royal Brisbane and Women's Hospital speech pathology team for benchmarking and resource sharing. negotiation of the use of existing telehealth systems in each of the 5 sites, establishment of buy-in from stakeholders from each site. So that included facility managers, directors of nursing, allied health assistants, speech pathologists, nursing and administration staff. We developed a service procedure which was later endorsed at the health service level. Speech pathologists and allied health assistants completed training which included the RPOC online training and practical simulation sessions to start with. Dysphagia kits were sourced for each site with all necessary equipment that would be required during the session, so lapel microphone, torch, pulse oximeter and other consumables. The service was initially rolled out across Banana, so Billawheeler was the hub for the outreach sites, and then shortly after, implementation was expanded to Gladstone, which was then the hub for Banana when there was no local speech pathology coverage. Following 12 months implementation, service outcomes were evaluated and findings indicated that there were 36 occasions of service delivered in the 12 months. 100% of patients were seen in the facility they were referred from. 100% of inpatients and outpatients were seen within recommended wait times as per our service prioritisation guidelines. 100% of patients consented to participate in the telehealth service. 100% of patients surveyed agreed or strongly agreed that they were satisfied with the service, and regular teledysphagia training for speech pathologists and allied health assistants was completed in order to ensure maintenance of skills and upskilling of new staff. So reflecting on the project now, the teledysphagia service is embedded in usual speech pathology practice across Gladstone and Banana, and it's written into the role descriptions of speech pathologists and allied health assistants. The telehealth service has been utilised opportunistically and where clinically indicated with other patient cohorts. So it's been utilised in partnership with tertiary facilities such as Royal Brisbane and Queensland Children's Hospital for clinical support and clinician upskilling in more complex areas, so head and neck cancer and paediatric dysphagia. Professions from other disciplines, for example, physiotherapy, have been trained to provide the client and support for the teledysphagia service to ensure that the service continues 5 days a week all year round. So for example, if an allied health assistant's on leave, we can still deliver that service. The Banana Allied Health team have also explored further directions with telehealth in other professions, including occupational therapy, home assessments, dietetics consults, and physiotherapy mobility assessments by telehealth. The teledysphagia project inspired change among other speech pathology teams within the health service, and it's now being rolled out in Rockhampton, Mount Morgan and Yeppoon. And resources developed throughout the project have been shared with other rural speech pathology teams in Queensland, including Claremont and Mount Isa. Overall, the Rural Generalist pathway has enabled service improvements across the Banana region and inspired the local team and wider health service to explore other service changes that are innovative solutions to the challenges we face in healthcare. For me personally, the Rural Generalist program has been very rewarding and it's enabled my own professional growth. It does require a big commitment to study both inside and outside of work, but I strongly believe if you get the opportunity to participate in it, it is worth it, and there can be great outcomes for yourself and also the service. But thanks for your time, and if you've got any questions, you can email me on that address on the screen.
Great, thank you, Emma. All right, well, we will keep moving at the moment, and I am just having a look. We are starting to get some chats in there, which is nice. I can't see them at the moment, so hopefully Kath can.
Yeah, they're just me issuing instructions. So. So no questions yet. Just a reminder to everybody, when you have questions, please use the chat function there.
Here we go. Okay. Now, next person.
I was going to say you could keep control just for ease at my end if you're happy to.
No worries. I will just get control back. Oh, that's the story of my life. Trying to get control back. All right, Lisa, it's over to you. Just give me a nod when you need me to change the screen.
Okay, will do. So thank you for having me today. My name's Lisa Baker. I'm the Rural, Allied and Community Health Team Leader based in Gayndah in Queensland. Close neighbours to Emma up in Biloela, though we actually don't really see each other in person, though we're a few hours away. So thank you for having me speak with you today. Unfortunately, Frances Lavis, who is our Rural Development Pathway Psychologist, was unable to present today, so you're lucky you've got me instead. And before I jump in, I would just like to acknowledge that I think for these programs, there's a whole lot of work that goes into the background, be that with Sarah and Katzend, Ilza, Nielsen, our kind of key player in Queensland, but also for the psychology supports that we've had as our team was implementing a new psychology position to the team. So we're not only starting a new position, but also the projects as part of the pathway. So our project period was from June 2017 and Frances completed the Level 2 program in December last year. She had a fine evaluation in Bundaberg with a big bottle of rum in the background. So just to put in mind where Gayndah is, we're not too far from Bundaberg. So our service development focus was really about the development of a psychology service for people with chronic and complex health conditions. For us in a rural area, it's not often possible to access mental health supports, but we were really wanting support in that chronic condition space. So part of the development focus was also then the development of new models of care, and the project involved implementing mixed service delivery modes and also a group sleep clinic. So the service development description for us, it was developing a new psychology service, and I think really making sure that new service met our rural area. It needed to meet our demographics and the geographical challenges for us. So the challenge of those of hospitalisation risk and readmissions, and then adding in the distance. So that was a particular focus. From a psychology perspective, I'm a speechy by background, just so you're all aware. So in terms of it really was looking at helping people through those changes and stages that fits with their individual life and meaning and their purpose. So a lot of the work that Frances has done is breaking down a lot of the barriers to access, and also, I guess, providing our local health team who had a psychologist for the first time some of that support working with chronic patients, and that might be adherence to treatment recommendations or building her supports into our existing programs. So service development activities, thank you, Gemma, was really looking at the development that occurred was around the referral processes. Frances implemented the HARP Chronic Condition Risk Calculator tool, and that's just a tool that really helped us in some ways separate out the mental health psychology role to our chronic disease one. It helped to identify referrals, prioritise her wait lists. It also helped inform clients about what the focus of the service was and what the intervention may be. And it also then, I guess, also worked as kind of a promotion to the local doctors and allied health and nursing teams to raise the service profile and I guess get a more focused referral pathway. The second part we looked at was the service information sessions, really getting that information out there to the people referring and also to our small communities. And the final part that Frances really focused on as a new psychologist to the team on the pathway was developing an orientation manual. We've all been there in rural areas where the service falls apart when someone leaves. So how could we really make sure that was set up well for either her leave periods and also for that sustainable service model. So for me as a team leader in the rural space, that was really important to assist me in that space. So Frances also spent a lot of time as part of the development pathway developing and collating clinical resources. You know, a new service implemented in a rural area without a team of the same professionals around you certainly has its own challenges. So we use the training and development part of the pathway to really assist her to do that and target her training. She's also made sure, setting up a new psychology service in a rural area, that we had that multimodal approach. So we did include face-to-face clinics. We also included from the outset a telehealth and telephone and e-intervention model. So that was an important aspect for us to get a good fit there. In terms of reviewing the service and client data, that's been an important part of the pathway, and a lot of the training involved helped Frances to really look at that local service need and to monitor and evaluate the new services she was putting into place. So that informed the ongoing service provision, but what it also did was to assist with that promotion of the new service, that we kind of come in and expect people to understand what we do, which sadly we know isn't always the case. And then the final part on this slide is, I guess, that part which was utilising the Pathways individual learning plan. So we could really target for a psychology service a lot of the spaces around a clinical psychologist role or a generalist psychologist role, a health psychologist role, and in our rural area we kind of needed it to be a bit of a mix of those parts of a psychology position. So it helped, I guess, that the pathway helped really direct that learning into the chronic condition space that we needed it to be. Thank you, Gemma. So in terms of findings and outcomes, so service outcomes, we're already seeing it's now part of the service. We're 2 years in, and we see it embedded into our model of care locally and our services that we offer. We definitely saw the increase in service by that 2nd year of service. That the training pathway does take a lot of time, and we saw that development pathway, but we acknowledged that up front. So it kind of wasn't expecting a psychologist to come in and have the same caseload as a podiatrist, sort of, you know, half an hour appointment. So we acknowledged that, but we also recognised in the 2nd year we did see that big jump in occasions of service. Somewhat for us, a little bit surprisingly, we saw that the split of face-to-face to telehealth wasn't quite what we expected it. We thought it might have been more of a 50-50 split. And we saw the preference for that face-to-face, which we all understand, was actually quite important in that complex chronic condition aspect. There were telehealth services available, but for many of our clients and in the demographic that we work with, having that face-to-face connection was actually a really important one to be mindful of, while still offering that telehealth and telephone service. So we could really match what our patients wanted and needed while being mindful of having that mixed mode. We saw nil hospital readmissions, and considering the complex space that Frances is working in, that was really important. So from the client feedback, we did some sort of snapshot approaches with Frances in her review and looking at the outcomes. So she had some really great and positive feedback from clients, as we understand in rural areas just may never have received that service in the past. So I think that feedback approach of, you know, you're asking things and making me look at it another way that I never had before. So so that was nice that we could demonstrate that and share that with our team locally and those that are referring into the service. So next slide being outcomes and learning. So look, the benefits of this project were really that we saw initiation of an aspect of healthcare that is often overlooked in our rural areas, and that's their psychological and emotional well-being. We can get so caught up in their physical care that sometimes we do omit that to some extent, whilst we're doing our best, of course. So we really found the service was providing that collaborative approach and seeking to work together and work with referral pathways to give that holistic care that is so important to our communities out here. We saw that the chronic pain, which if you've read the rural papers, we know we have a much higher rate of that in rural and remote areas, and that was a particular focus area. So, you know, we've developed some particular programs in that space and utilising some of the E programs around that as well. In terms of that health management perspective, really looking at that meaning and purpose and acceptance of conditions, be it cancer or chronic pain or whatever condition the patient may have been living with. So the final part that we really saw was that teamwork, and that's so important to us all, but really supporting that peer consultation and that discharge planning together was a key part. So just reflections. The project work is intensive. It was, you know, it was a lot of training, and there's that personal and professional impacts with that. But I think much like Emma, Frances was still clear in terms of it was really important, and that would have been much more difficult without this program to support her through that new service implementation. From my perspective, we've definitely got now a robust and skilled rural psychologist. We don't just have a grad or someone new to the role. We really have got someone that's working for our communities and addressing their needs. So at a team and local community perspective, it's great to be able to promote how the Rural Pathway has assisted our team, and Frances in particular as our rural senior psychologist in that space. So that's probably the main bits from me. We're certainly happy to chat if services want to make contact. We really are just at the end of an email and then phone call, so feel free to make contact with either myself or Frances. We're always happy to chat how we might work together. So thanks.
Thanks, Lisa. And just if you haven't got the slides, we can make sure that we can forward those after the presentation with the contact details on them as they are. So next, Angus and Anna in just down the road from me in cold and wet Tassie. I will hand over to you. Do you want control, Angus, or do you want me to do it?
No, you've got control, Gemma, that's fine.
Thanks.
And it's just me, and it's not here today, so.
Okay.
Yep. All right, good to go. So I'm a podiatrist and commenced the level 1 training program in January last year and completed the training in December last year. We implemented a service development project focusing on improving access to quality medical grade footwear for eligible Northwest Tasmanians. So we had the project run from basically when I started until just recently in February this year. So what we set out to achieve was improved access to custom made and extra depth/width medical grade footwear. We wanted to improve the quality and the timeliness of the products, and we wanted to improve, if possible, the cost effectiveness of the products that we get for our clients. Anecdotally, the current process was slow quality and the quality was questionable. Correct fitting footwear with accommodative orthosis is known to aid in ulcer prevention, so we're really keen to see what we could provide for our consumers. All right. To implement change, we did a bit of a service review. Had a survey and a questionnaire of our staff, and the staff generally reported that they had negative perceptions of the current process, particularly in regards to quality and the timeliness of the product. So we did a bit of a review of the past 5 years on the average timeframes for, I guess, identification of a need to prescription of a custom shoe, and the average time for dispense from start to finish was 251 days, and even up to a year in some cases. So we had a pretty big issue there that we wanted to try to improve. So we ended up sending Anna up to Sydney to a therapeutic shoe fitting course run by the Podiatric Association of Australia. So we use this as a networking opportunity to try to identify possible suppliers that may be willing to work remotely or engage with us to have the podiatrist do part of the fitting process or casting process. So we identified a supplier out of Melbourne who we got a reference from an orthotist that was working in a similar fashion. So the orthotist was casting for the footwear, and the lab was producing them. They were being fit and then signed off by the podiatrist, and generally within 6 weeks. So it's a far improved time frame. So with that, we developed a process for accessing interstate orthotists who ended up coming down and upskilling the podiatrists in casting and prescribing the shoes. Next, gentlemen. So the outcomes that we set out to achieve, we managed to improve confidence in footwear casting and prescription for our podiatrists. So prior to the project, our staff weren't confident in casting or prescribing footwear, but after the training we implemented, we had an 85% of staff reporting confidence in being able to cast and prescribe for custom footwear. The footwear supplier has offered telehealth support to clinicians for casting and prescribing. So all we had to do if we were concerned at all or had any questions is get them up on FaceTime with and have them assist us in the process. As a result of this, we've vastly improved the access to custom-made footwear within Northwest Tasmania. Previously, in previous times, the patients or consumers would have to travel to a major location for casting or fitting by the current podiatrist. But now our podiatrists are able to do this in any location, whether it's King Island, Queenstown, Smithton, or Devonport. We have a far greater reach now. And along with that, by having an extra supply now, the consumers now have a choice to choose who makes their shoes, whether they wanted a specific design with their shoes. We have the option to do that now as well. Next, gentlemen. Unfortunately, due to time constraints with the project, we had a few outcomes incomplete or unable to be evaluated. So we weren't able to improve the timeliness or assess whether we'd improve the timeliness for the provision of footwear. This is due to us being unable to actually prescribe any new shoes during the project time. And this was mainly held up due to other projects that we're running within the organisation, particularly around funding for footwear. With that, we're also unable to evaluate the quality. And again, for the same reasons, we just didn't have the footwear to evaluate. However, the project did allow us to obtain a fancy bit of software, which was an F-scan, which for those unfamiliar to podiatry world, is a in-shoe plantar pressure mapping system. So we can pop an insole in a shoe, work out where the high peak plantar pressure sites are, and then evaluate our intervention. So check whether we've taken the pressure away effectively enough to heal or prevent an ulcer from recurring. And unfortunately, as a result of the project, we weren't able to improve the cost effectiveness of the products specifically. So the new supplier was considerably more expensive for custom footwear than the current supplier, but more cost effective than other suppliers that we did evaluate. That being said, the new footwear that we're looking at, or we've engaged with, they produce the accommodative orthoses with the shoe. So that may be a cost saving item down the line where we won't need our orthotist to produce an accommodative footbed. It'll be all done in the one transaction for the footwear. Thanks, Jim. So I guess our evaluation and learnings, we've managed to enhance the skills of clinicians, which has resulted in far greater consumer access to custom footwear regardless of their location. Purchasing the F-scan software has allowed for in-shoe pressure analysis and on-the-spot shoe/orthotic modification prior to footwear acquittal. And this has the potential to vastly improve patient outcomes. And this is for the first time in Tasmania, we'll have one of these pieces of software in all regions of the state, so north, south and northwest. So we're going to have to conduct ongoing evaluation, and this will occur over the next 10 months as we start to have clients that require custom-made footwear. I guess one of the big learnings is that if you find a consumer that's, a provider that's willing to work with you, this sort of remote, or I guess delegation in a way, is applicable to other podiatry departments within the state of Tasmania or within other podiatry departments in regional parts of Australia. Thanks, Gemma. So for me, the Level 1 Rural Generalist training has ensured familiarisation with the local organisation and has provided me with an introduction into remote service delivery strategies. It's provided me with the opportunity to be involved with a project, which otherwise I would not have had the opportunity to be involved with at this stage of my career anyway. And working on the northwest of Tasmania has highlighted the importance of remote service delivery, including skill sharing and delegation for these types of reasons. Thank you.
Thanks, Angus. It's great. I was there when Angus started at the very beginning of his project, so it's great to see it presented. Just a reminder, we do have some questions trickling in, so if you do have any questions so far for Emma or Lisa or Angus, pop them in the chat function and we will follow them up at the end of the showcase. So moving along to Maddie, another Tasmanian. Are you there, Maddie? Also down the road. Oh no, well, further down the road. Would you like control, Maddie, or do you want me to?
I think it'd be good if, yeah, if you could do that.
No worries.
I don't really know how to work it, but thank you. Okay, so my name's Maddie. I'm representing Launceston and General Hospital with the implementation of a post-acute occupational therapy service. So we trialled this project from February to November last year, and our sponsor was Kendra Strong. So the aim of this project was to explore, develop and trial a short-term post-acute OT service that supports patient recovery at home following discharge from the acute medical or surgical wards in the hospital. So this project was created in response to increased OT service demands, which forced a narrowing of our scope, particularly on the acute wards. So this resulted in limited follow-up of discharged patients, including patients who are at high risk of readmission or discharging with complex equipment and home modifications. Best practice supports OT follow-up for patients at risk of readmitting, particularly those at risk of falls and discharging with high care needs. And we chose to use a telephone follow-up service as a low resource alternative, with home visits only conducted if clinically indicated. And this also enabled us to provide a service to our rural clients who weren't often eligible for our existing transitional care services, such as TCPC. So to implement this change, we conducted a review of the literature, which focused on the OT role in reducing readmissions, and also looked into the efficacy of telephone follow-up in reducing readmissions. We developed a number of outputs, including a referral tool to the service, a collation of resources to provide to clients based on their needs, a telephone script to assist the OT in identifying risk factors for readmission, and the discharge criteria and process. Once the resources and processes were in place, we implemented the service and refined it as needed. The usual timeline for a patient involved an initial phone call 7 days after discharge to identify their needs and also to look at any risk factors for readmission. Based on this information, resources were mailed to the patient. So common resources were things like falls prevention packs and information on my aged care. A second phone call was placed 2 weeks after the first to check in and go over information sent in the post. And a final phone call was placed at 3 months after initial discharge to determine if there were any adverse events and to record an outcome measure of occupational performance. Onward referrals were placed if further follow-up was required. So these referrals were often to falls and balance group or to community OT. So we evaluated the service by comparing admission and discharge scores on the autonomy assessment scale, which I'll talk about a bit more later, and determining number of adverse events as per client self-report. So moving to the next slide. The first outcome we looked at was improved identification of high-risk patients. So prior to the project commencement, no resources were available to assist OTs in identifying these patients. So a checklist was developed as part of our referral form to assist OTs in identifying high-risk patients. So the referral form included things like having more than 3 falls in a year, having a fall in hospital, having a pressure area, and other things like that. Overall, the service received 39 referrals with 32 clients meeting referral indicators, and this suggests improved identification by acute OTs of at-risk patients who otherwise would not have received any follow-up. The second outcome we looked at was increasing support for discharged patients through information, onward referral, and home visits where indicated. So we recorded data on type of education and intervention provided to participants. We found the most commonly provided client education was related to management of fatigue, greater return to activities, and information on how to access additional services and supports from my aged care. 15 of our clients received onward referral for further follow-up, usually for community physio, home modifications, and falls and balance group. As these clients would previously not have received any further OT follow-up, the provision of these interventions indicates increased support at discharge, and several clients reported finding the follow-up reassuring, and it was a type of follow-up they weren't receiving from any other service. So moving to the next slide. The third outcome we looked at was improving occupational performance of discharged patients. So we measured this by using the functional autonomy assessment scale at admission and discharge from the service. So this scale provides the use of 2 scores. The raw score measures an individual's functional ability without resources. So resources could be things like services or family members or equipment. And the adjusted score measures if available supports and resources meet the person's occupational performance needs. So as shown in this table, there was a change in raw scores from admission to discharge, and that indicates that on average, the patient's occupational performance level increases after discharge. The adjusted score wasn't clinically significant, but overall it shows a trend towards more available resources after discharge. The final outcome we looked at was reduced adverse events at 3 months post-discharge, which we achieved with some limitations. Falls was the first thing we looked at. So at 90 days post-discharge, 20% of our participants had a fall. And while this number may seem high, the clients referred to the service were identified as being a high-risk population compared to the general population. The literature I could find suggested that up to 40% of older adults fall within 6 months post-discharge. So whilst the number is high, it kind of fits within that realm. Looking at readmission, 20% of participants in the follow-up service were readmitted within 90 days. Digging a bit deeper, the reasons for readmission were primarily medical in nature, so and didn't have the potential to be prevented by further OT follow-up. So looking at reflections and key learnings, the takeaway message of this evaluation for me was that there is a space for OTs in preventing readmissions and reducing adverse events after hospital, particularly in regards to reducing falls and identifying and prevention of functional decline. As shown previously, the outcome measures indicated that the clients showed some improvement in occupational performance, and clients also reported feeling reassured by the service and appreciated the increased support and discharge, so that was nice. The service also benefited from having a dedicated post-acute position, and the telephone follow-up provided a low resource alternative to providing home visits for every high-risk client. And looking forward, future iterations of this service will likely involve a combination of both phone calls and home visits where required. A recommendation for other rural teams would be to consider delegating to an advanced scope AHA, who may be able to complete some phone calls and report back on any red flags that indicate urgent OT follow-up. Yeah, so that's everything. If you'd like to contact me for more information, feel free. There's my email address, and I'll hand that back over to Gemma.
Thanks, Maddie. As with Angus, it's great to hear the results of your Tassie project. All right, moving along to Murrumbidgee. Is Ellen around? Do we have Ellen? Or anybody in Ellen's place presenting on this project?
I'm sorry, I'm here.
There you are.
To unmute me, but I have to unmute me, so that's great. Thank you for the opportunity, and I would like to acknowledge the traditional owners of the land that we are all meeting on right across the country, and I'm standing on, or sitting on, Wiradjuri country at the moment. I pay my respect to elders past, present and emerging. So I'm happy for you to move the slides on for me, please, Gemma. That would be great. So just a quick overview where Murrumbidgee sits. We're in the southwest of New South Wales. So next slide, thank you. Our problem in Murrumbidgee was that we had patients and no physiotherapist at sites where there was positions. The sites that we did implement our project with the Rural Generalist pathway in New South Wales were Tumut, Temora and Deniliquin. Just a bit of background is that New South Wales hasn't got a state-based implementation plan for the Rural Generalist pathway at this point in time. So we were using some resources that were already existing. Outside of the main centres in Murrumbidgee, all 4 of the permanent full-time physio positions were vacant in 2016 with recruitment and retention issues. Next slide, thank you. So some very clever and innovative leaders in our organisation decided that they would redesign our workforce resources, and from the 3 positions, level 3 positions, they created 3 level 1-2 positions with a shared supervisor resource. Next slide, thank you. Again, back to our geography and the locations. So the red stars on this diagram are where the key primary sites were. The purple triangles indicate where outreach sites, outreach services were set up. The blue star is where I'm based, so I'm the senior on the position on the project. And just as an addition towards the end of the project, the yellow stars are 2 additional rural generalist sites that have come on board in 2019. So next slide, thank you. So looking at just the service development, service development part of this project, we started with vacant positions. So part of the service development was establishing the positions in these rural sites. These are sole practitioner positions for these physiotherapists. So it was about protecting those early career physiotherapists and managing their scope and workload in a potentially busy site. So all 3 sites, there was no service. In one case, there was 4 lots of 2 hours of private service per week. So the next stage was setting up the equipment. It actually took 6 months just to get a webcam. So when you're doing the multimodal supervision, so face-to-face plus telehealth, it was quite a long time just to get equipment when we were not, specifically resourced for this project. So there was quite a lot of challenges even just with setting up. We, the supervisor did frequent visits to the site early with a reduction in frequency as the skills of the clinician, skills and confidence of the clinicians at the sites improved or increased. Also, we started just with the basic inpatient and outpatient services, and as we assessed the needs of the community, there was a gradual development of the scope of the services. So go to the next slide, thank you. So just a very brief overview if we consider service development. There was a gradual increase in just occasions of service. This is a little bit old, this data, but that continued to increase and has now plateaued. So we'll go to the next slide. So services that developed with the increased capability of the clinicians was just some examples were some more systematic and multidisciplinary team approach to rehabilitation, pulmonary and cardiac rehabilitation, physiotherapy input, some strength and conditioning and wellness groups developed, which was aligned with our organisation's goals. Working with allied health assistants was a large part of it, although in one location there was no allocated allied health assistant. So there was in a different program, and they worked very hard to develop ways of utilising that resource to benefit the patients and improve the capacity of the service. So we did some work with some professional development in women's health, developed resources for the ward and also community services. And as I said before, with our patients, they start with a small scope and gradually expand that scope. Also developing partnerships to work with private providers as much as possible so that we're not duplicating services. Outreach services were established, and sometimes these had existed previously but been poorly maintained, but they were, once they were regular and established, there was very good uptake of these services. Other examples included Stepping On program, which is a falls prevention program, and a virtual fracture clinic, which Annie will present on shortly. And other examples were utilising the expert input of the Parkinson's physiotherapist to then run the clinics at the rural sites with telehealth input from the specialist physiotherapist as needed. And lastly, the establishing the residential aged care reviews. So next slide, thank you. So just in conclusion, the Murrumbidgee Local Health District Rural Generalist project, it set up a functioning service that had previously been vacant in 3 of the rural sites. It was multimodal, set up chronic care programs and establishing the hospital services. We used technology, so with the virtual fracture clinic as demonstrated in this slide. We had used telehealth for meetings, supervision, networking and patient care, which wasn't being done in Murrumbidgee very much before that. We had the wellness focus and preventative work, which often there is not the capacity to do that, but yeah, capacity is being challenged at this point in time. We developed the partnerships not only with the staff at the local facilities, but the local Aboriginal community groups and with the GPs, and with some skill sharing that benefited the patient care. So, for example, on the days of outreach, so that the services could continue, as well as working with the allied health assistants. Looking at services that were addressing KPIs like the key performance indicators like the falls prevention and avoidable admissions. We also achieved gradual increase in the scope and working with the allied health assistants, and with the district developing ways of working. So we've been tapping into a professional development program that's offered at Wagga just for the large Wagga team, that wasn't previously available to anyone else but is now available via telehealth. So we've built up the capacity and are contributing to the rural pipeline to help sustain services in the future. So an exciting development recently is the use of the Wagga-based hospital has developed a rural clinical school in physiotherapy, and there has not been any student placements available because there was vacancies at these sites. But now, as part of that project, the Rural Generalist sites will be taking on 2 fourth-year placements during this year. So that's 6 new fourth-year placements in the rural area that were not previously available. And just finally, workforce-wise, so we've gone from 0 out of 4 positions filled to 5 out of 5 positions filled by utilising this, the Rural Generalist framework. And it's also had an impact on patient flow, so patients are able to go from the large hospitals to the regional hospitals where we're delivering evidence-based practice and contributing to the health outcomes in rural communities. So Annie would next like to share a specific example of the project. Thank you.
Thanks, Ellen. Annie, are you there?
Yep, can you hear me?
Yes, I can. Yep, are you on phone or?
No, I should be on the computer, but it's not starting my video for some reason.
No worries.
You might have to do it manually, Annie. Bottom left-hand corner of your screen.
Bottom left-hand corner. Yep. Yeah, I'm clicking on it, but it's just not working for some reason.
Start talking. We'll see if we can fix it from this end.
Oops. Maybe I've got too many things open. So can you see it there now?
Can't see you, Annie, but we can hear you, so we might need to, can you see the slides okay?
Yeah, I can see the slides, yep.
So if Annie starts her presentation, we'll see if we can fix the video from this end. But Annie, I'd get underway if I were you.
Okay, no worries. So yeah, good afternoon everyone. My name's Annie Nicholas. I'm a physiotherapist at Temora Hospital. I commenced on the Murrumbidgee Local Health District Allied Health Rural Training Program in December 2017 and completed the 2-year position in December 2019, having partly completed the James Cook University Rural Generalist Training Program along with other professional development opportunities in fracture management, pediatrics and women's health. I've since stayed on at Temora Hospital as the level 3 generalist physiotherapist here. So it's my pleasure to be attending today and I'm going to present an evaluation on the Temora Virtual Fracture Clinic, which was a quality improvement project that I completed as part of my 2-year position in the training program. So I guess there was a light bulb moment that triggered the need for this quality improvement project. I saw a young gentleman out at West Wyalong, which is an outreach clinic that I do an hour from Temora, 2 hours from Wagga, who had had a tibial plateau fracture. He'd attended the fracture clinic in Wagga for further investigations and was fitted with a range of motion brace, which at the time was locked. And then he had to come back 4 weeks later. He attended, the fracture clinic 4 weeks later to have that brace unlocked. So I then saw him after that as an outpatient, and he was quite irritated by the fact that he'd had to travel, 4 hours round trip to Wagga just to have a knob changed on his range of motion brace. So there's the cost of the travel. His partner had to take a day off work. He had to take a day off work to get care for their kids. So there was a lot of reasons, I guess, as to why he was quite upset that he had to travel so far for a service that I guess could have been provided locally. So I guess the idea of the Temora Virtual Fracture Clinic emerged. So previously, sorry, next slide, Gemma. So previously, patients living in the Temora and surrounding areas were having to travel to Wagga for fracture clinic appointments, which placed a significant burden on patients, their families and carers due to the cost, time and stress involved in travelling to Wagga. The virtual fracture clinic allows patients with simple, non-complicated fractures to be reviewed by the orthopaedic team via telehealth and managed appropriately by the physiotherapist and nursing staff at Temora Hospital. So to assist with the project, we applied for the Edison program, which is a Murrumbidgee Local Health District initiative to support innovation in the workforce. We were successful in this grant, which allowed us to have support from the Murrumbidgee redesign team, and there was $1,000 that could go towards commencing the project. So once we started the project, we had to develop our project scope. So in scope was simple, uncomplicated fractures, and the referral had to come from the orthopaedic consultant or registrar. It was for follow-up consultations only. Patients were within an 80k radius of Temora, and it was to run in conjunction with the Wagga-based fracture clinic. So the Wagga-based fracture clinic runs on a Friday from 12 midday. So we had to organise our patients around that time. So out of scope was complicated fractures that may require further intervention. Any initial consultations for the fractures that had to previously be reviewed by the orthopaedic registrars or consultants. And if it was a pathological fracture, or a complex patient. Next slide. Thanks, Gemma. So I guess this slide shows the complexity of the project. So before commencing this project, I had a very strong dislike for Excel and flowcharts, but I've since realised that I just needed to be patient with them, and that the process mapping and flowcharts are really important as they allow for identification of the pool of patients that could add value to the process, as well as defining the complexity and geographical implications of the patient journey. So I guess this flowchart demonstrates the processes that are involved. There's actually 3 pathways for fracture management. It involves a large stakeholder team. So there was lots of negotiations between all these stakeholders, both at Temora locally, so the physiotherapist, the radiographer, the nursing staff, the facility managers here, the allied health assistants, in the community with the GPs, and then over at Wagga Base with the orthopaedic doctors, the physiotherapists over there, and the administration teams at the orthopaedic clinics. So there was lots of consultation involved in setting up this project. There was some resistance at the start from the orthopaedic consultants and orthopaedic teams. One of their requests, I'll just get you to go to the next slide, Gemma, was that they actually wanted us to show that this project was worthwhile. As I said, there was that resistance. So I guess they wanted us to provide statistics to show that there were people, or a significant amount of people around the Temora area that were travelling to Wagga. So we did a review of data for people that attended the Wagga Fracture Clinic for follow-ups based on their home location in 27 17-18 financial year. So there was actually 143 people from around the Temora area that attended that clinic as a follow-up. So based on that data, the orthopaedic team were in agreement that we could go ahead and run this project. So we jointly agreed on the scope, which I spoke about earlier, and the way that the service would be delivered. I'll get you to go to the next slide there, Gemma. So we officially launched the project on the 4th of November 2018, having commenced sort of the project work in February 2018. So we started seeing patients in October, and then, as this shows, we had the sort of local member and different executives from Murrumbidgee come and actually launch the project in November. Next slide, please, Gemma. So this is some old data. Unfortunately, I haven't been able to get the new data as yet, but these are the patients we saw in the 4-month period from October to February 2019. During this time, we collected 19 patient questionnaires. So they were our way of getting some feedback about the virtual fracture clinic. So over those 4 months, 2,661 kilometres was saved based on the 19 questionnaires that we collected. 100% of customers were happy with their overall experience, 100% satisfaction with parking. There was 100% satisfaction with the quality of care. 67% of appointments started within 10 minutes of their appointment time, with 100% starting within the first hour. On average, consumers saved 140 kilometres of travel per appointment, and 79% of consumers rated their telehealth consultation with the orthopaedic doctor as excellent. Next slide, please, Gemma. This is just some feedback that was written in the sort of other comments as part of our patient questionnaire. So it was quicker, more convenient, excellent, less time out of school, 10 out of 10, started straight away. And I've got one just in front of me here that says they didn't have to take the day off work. So we've had really positive feedback from our patient questionnaires. Next slide, please, Gemma. So I guess we're still working on areas of improvement. It's still an evolving project. So we're still having some issues with using electronic medical records and scheduling patients, data collection and how it's best to capture that, and what we need to be putting in terms of our face-to-face and our telehealth, because it's face-to-face at the Temora end with the physiotherapist, but it's telehealth at the Wagga end with the consultant. So yeah, still some fine-tuning that needs to go on there. We have now got a setup of a telehealth Pacific station at the Wagga end, but because we've got the redevelopment at Wagga and rooms are being used for different things, it's still a work in progress. And then selecting appropriate patients and referral for patients has been an ongoing issue because of the changing in registrars with the orthopaedic registrars. So when we get new registrars through, they're not always informed about the virtual fracture clinic, and then so there's patients that are missed because they're not referred into that. And then if our admin ladies are away at the Wagga end, then patients are also missed. So it's yeah, still a lot of fine tuning to happen in regards to that. Next slide, please, Gemma. And I guess where to from here? As I said, we've still got some fine tuning that we need to do, but I guess the plan is to expand this to other sites, and how do we do that? Is there a different model of care, or is it best to keep going with the way that we're doing? I guess our biggest one is increasing the engagement with the orthopaedic team, and making sure that the patients are picked up, and it's not always sort of the physiotherapist on site going through the list each week and seeing who is appropriate, and then doing a final evaluation report of the project. So based on our questionnaires so far, in terms of the patient's experiences, it's definitely been a successful project. In terms of the delivery of care, there's still, and staff satisfaction, I guess there's still some areas that we need to improve on there. And it's just been ever evolving, even with the changes in the way that we're doing our telehealth. We were using the PEXIT format, and that's now gone into the virtual hub, which is still PEXIT as a background, but just a different way of seeing patients. So as we all know, telehealth is ever evolving, and I think this project will continue to be with that. The final point I'm going to make is that, as I said, it is expandable, and we've also used the telehealth in our inpatient setting as well with fracture management. So I guess finally I'm just going to leave with a bit of a patient story, because it's always just nice to hear what the patients have to say. So I guess this is just an excerpt from a patient story that we put together. So James is a young male with Down syndrome who lives with his mother in a country town about an hour's travel from a major regional centre. James is usually independent, mobile, loves his dancing, Netflix and Wednesday night takeaway night. The day before James was to put on his dancing shoes and head to the city for a night out, he fell down some stairs and badly injured his ankles. He agreed to talk about his healthcare experience and the management of his injury. He agreed to be interviewed by an MHLHD employee with his mum present. So leading up to the orthopaedic clinic review, James was still a sling lifter and had a fair amount of pain due to having bilateral ankle fractures. The physiotherapist liaised with the GP and the orthopaedic team at the referral hospital and set up a virtual fracture clinic review. James had x-rays on both his ankles prior to this review, was set up in his room with the telehealth technology. The telehealth review was facilitated by the local physiotherapist on site and the administration personnel at the outpatient clinic. The on-site allied health assistant also assisted the physiotherapist. The orthopaedic registrar reviewed the x-rays and a plan was developed. James needed to have his back slabs removed, have a wound review completed, and go into a fiberglass cast on his left leg and a weight-bearing cast on his right leg. So the plan was completed by the physiotherapist, the registered nurse at Temora, and assisted by the allied health assistant. James describes his telehealth experience as, "I got to stay in my king chair. It was much better to be able to look at the computer screen. It saved me having to use transport. It was quicker and I got to stay close to my family. I had to have my stitches out, which was not good. It frightened me. So it was good to have mum there. And I got to pick the colour cast that I wanted. I chose pink." James's mum described her experience as, "It was much easier. It saved a lot of hassle of having to move him again. He's been in so much pain. With the pain he was in, he wouldn't be able to tolerate the transport. We got an instant result. It would have taken hours otherwise if we had to travel and have the x-rays and review done off-site." So I guess finally on reflection, the Allied Health Rural Generalist training program was paramount in this quality improvement project. It provided the professional development time allocated towards the quality improvement project. There was supervision and there was support from the senior physiotherapist as part of the program. Thank you.
Thank you, Annie. While you're, we'll get you to just hang on there for a second, because there were a couple of questions and comments for you. Firstly, people were very impressed by your flowchart, so thank you for that. I think that came from Lisa. Annie, great project. Have you had a look at the impact on ABF funding for introducing this service, i.e. where is the activity counted and where is the funding directed?
Oh, ABF funding for introducing this service. Can you still hear me there?
Yep.
Where is the activity counted and where is funding directed?
I think this was probably in relation to the fact that you've got a physio at one end and your orthopaedic specialist in the Wagga end. And is this question from Kendra? Is that Kendra? Is that what I am? Am I interpreting that correctly?
Yeah, it's Ellen here. I can answer that. The funding goes to the Wagga orthopaedic team, and the physio is funded just out of usual district funds. The district does receive an incentive payment because it's a multidisciplinary activity and telehealth as well.
Thanks, Ellen. And a question from Ellen to Annie. Annie, what happens when you are away? Oh, and have we lost Annie altogether?
Can you hear me now?
Yes.
Sorry. Yeah, unfortunately the service doesn't continue when I'm away.
All right. Any other questions for Annie while that presentation is fresh in our heads? Nope. Thinking about, Maddie, thinking about your presentation. Oh no, that one's already been asked and answered, just about allied health assistants and their ability to participate in this telephone screening. A question for Angus. How did you find completing the level 1 education in 1 year? Are you still about, Angus?
Yep, I'm still here.
Yep, lovely.
Yep. I didn't find it too bad with the clinical split. So I did 50% in the clinic and had 50% of my time to do project work and or the training program. So I didn't find it too challenging at all. I guess I didn't have to adapt to being a new clinician. I'd already had a few years of clinical experience as a private podiatrist, so I wasn't really, I guess, exposed to being a new clinician providing treatment and all the new graduate things at the same time. So I guess that probably helped me out a little bit. Yep.
Thanks, Angus. Any other questions for Angus? Well, no. Thinking back to Emma's presentation, Emma, question from Kim regarding the rural generalist training, and does it cover how you work with allied health assistants?
Kim, when I did the stage 1 of the rural generalist program, there was a subject that was focusing on delegation to allied health assistants. It wasn't actually available at the time that I did it, so I think it might be now. But the Gladstone and Banana Allied Health team, we actually did delegation training as a team through the Cunningham Centre, so that's also another option.
Thank you, Emma.
Emma, can I jump in on that one too, just around the telehealth dysphagia service? Part of the training that we have in Queensland on our e-learning system in this model of care has a whole host of video training and tools to train the allied health assistants in that dysphagia model of care via telehealth. So in that specific project, there's a lot of that in there too in the actual model.
Thanks, Lisa. Any other questions about Emma's project? No, so I'll just open then the questions. Is there anybody that has any questions or general discussion about the Allied Health Rural Generalist pathway, or have any questions that they want to direct to either Kath or myself or any of the other people that are attending today? Silence.
And we might invite people to unmute their microphones and speak. I think that we've got a manageable number of people online at the moment. So if you have any questions, just unmute your microphone and speak.
Kendra, I can see you're talking, but I can't, and you look like you're unmuted, but I can't hear you at the moment. You're going to type your question? Okay. A little bit of sign language there. Was there anybody else while Kendra is typing?
It's Ali Demott here. Can you hear me?
Yes.
I'm actually evaluating the Rural Generalist pathway in South Australia, and through Flinders Union I'm making it into my PhD project. And I'm just wondering if there's anyone else doing higher research degrees in this area.
Hi Ali, it's Ellen here. I feel like it is a PhD project to try and do the evaluation of the Allied Health Rural Generalist Pathway project. So yeah, good luck with that, and I look forward to hearing the outcomes. Not doing higher degrees at this point in time.
Okay, thank you.
Ali, it's Ilse Nielsen from Queensland. There's not, not that I'm aware of, like not specifically on the pathway. There's obviously people doing sort of, workforce-based research around rural, but just in terms of formal research, so Chasey, you were just about to complete a research project related to our 2017-2018 implementation in Queensland, and we have just gone out now. We're in the process of procuring an external evaluation provider for the period of 2019 through to 2022, and that will be done under a research governance framework.
Okay. Once you get that underway, do you want to let me know? Because that person, because I haven't found anyone else that's doing formal research in this area so far.
Yeah, not of the Allied Health Rural Generalist pathway, like not as an individual HDR project. Research projects.
Lots of evaluation.
Yeah. SCU did Southern Cross did a evaluation. Yeah,
I've got that. Thank you. Excellent. Well, we're 12 months down, so it's going well. Thank you.
Thanks, Ali.
So thank you. There is a question from Kendra. Can you give an update on where you're at with the announcement of support for the Allied Health Rural Generalist, i.e. with the private sector? So CW, is that an acronym that?
It's the Commonwealth. Minister Coulton's announcement.
Sure, yeah, thank you, Kendra. We have, so with respect to the National Rural Health Commissioner, people would be aware that he released his interim report a couple of weeks ago. And there were a number of very high-level recommendations there, which Sarah are broadly supportive of. The key thing about his interim report is that he is currently now developing up an implementation plan at the request of the ministers. So, which means that by the time he's finalised his work, there should be an implementation plan and, importantly, a budget to go with it. So, that's the state of, that's the current status of the National Rural Health Commissioner's work. With regard to ARGWIS, so thank you, Robin. ARGWIS, so Gemma and Ree started back in December before Christmas. They've been busy plugging away on developing up a detailed project plan, program guidelines for employers, and starting to reach out and engage with employers. And for those who are not aware, the ARGWIS, the Workforce Education Scheme, is looking at ways to engage with people in the private and not-for-profit settings. So I think we've heard today some excellent examples of the proof of this concept in state-based health services. And what we're seeking to do is to expand this into the non-government settings. So we're very pleased to say that in the last week or so, we have signed 2 contracts with two separate employers, one in New South Wales and one in Tasmania. And so we now have 7 additional trainees on the pathway. So we've got 4 in New South Wales that are doing the postgraduate diploma level, and we have 3 in Tasmania who are doing the level 1 traineeships. So off to a strong start. We are now managing the impacts of the COVID-19 mitigation strategy on our project. So what we were going to do was to approach a lot of the different professional associations and speak directly to people through their conferences, but obviously a lot of those are being cancelled now, and we're looking at alternative ways to reach out to both trainees and to employers. So, but we're off to a very strong start, and I'm sure that if there's any further questions there, Gemma and I are happy to take further questions on that.
And if you know of any fabulous providers in your area that would be interested, definitely promote away, put them in contact with us. Ilsa, you're laughing at my brazen promotion there, but
I was laughing at Robin Adams' facial expressions, because she
that was also
but also yours, Gemma.
yes, so do share. Sorry, Laura.
Hi Gemma, it's Laura from the Rural Doctors Network. Good to see you, and thanks for the presentations, everyone. They were great. So we're really keen to promote as much as we possibly can and connect across through all of the rural workforce agencies. So please let me know when you've got the material ready to go. Yep. We've also just put our refresher course, which was designed for GPs, but we've extended it out to allied health nursing and the whole of health workforce. Given, as Kath has mentioned, conferences, etc., having to be either postponed or cancelled, our refresher course was due for the end of this month. That's going to be online. So an opportunity for us to promote to that broader audience as well, Rural Generalist program.
Well, I think we're catching up on Monday, aren't we? So let's add those things to the list and chat. Yep.
Sounds good. Thanks,
Thank
Emma.
you. Thanks, Laura. Any other questions or? No. Okay, well, if you think of anything, email them through. My screen is telling me that my internet connection is becoming unstable because it's raining here. So if I freeze, I apologise. If you think of anything, please email it through. We'll get through a copy of the slides for you, so you can follow up on any individual presentations if you'd like. We're also, I guess, one of the other things to update you on is last year, many of you will have been aware, we had the PGG, the Project Governance Group, which had its last meeting last year and will be evolved into a new group with a more relevant function to how the Allied Health Rural Generalist pathway looks at the moment. That evolution process is underway, so as soon as we have more information, we'll be in contact with you, very important stakeholders, to go forward. So thank you very much for that, and thank you for your patience, and thank you for attending today, and we'll speak to you soon.
Thanks very much, Gemma, and thank you everybody for attending. Thanks.